Okay. You asked about what is the maximum size of implant I
Right.
used so far. Yeah. First of all, I should say that as soon as the implants get bigger, the problems and complications in the future gets bigger. So big implant is not a good thing, but sometimes patients really require some big implant as much as they can have. So we have got some criteria and some kind of measurements. We have to measure the chest diameter is very important, and also the diameter of the breast itself. So we have some limits, and in these limits, we put the implants, according to their wish, of course, as big as they can have. And if you put a big implant, the first important thing is to conceal the implant under the muscle to give the most natural result it should be. And we put it mostly under the muscle. This is the first thing. The second thing is also we should warn the patients that big implant means bigger burden here, because in the future they may sag. They should know that. And that's what we do. And in my life, I put 1050, which is the biggest implant in the world. Yeah, it's only in some brands. Most of the brands don't have this volume. But it was a patient who had already 800, and she wanted to replace it with 1050. I did it twice because I remember it was so big. But most of my preference.
And what is the size like?
You can't believe. I mean, it's really very big. It is really unbelievably big. But except that, most I prefer an implant in between 300 to 350, which gives enough volume, it looks natural, and risks and complications in the future is really very, very low.
I see. And you told me that if the implant gets sag, does it happen always the sagging of the implant, and what to do in this case?
Well, if it happens, the only thing is to replace the implant and make a kind of breast lift surgery to lift the breast again.
So you cannot just to do a small correction to lift the breast.
Come again? I didn't understand.
You cannot do a small lifting without changing the implant.
Well, there is no small lifting. I mean, lifting means at least we should give the patients a scar vertically or sometimes horizontally together. And in breast lifting, there is something that we should respect to give a long-lasting result to the patients, that the flaps should be like, there are some like 5 or 6 centimeters, because breast is always getting a little bit lax in the future. Whatever you do, any operation, doesn't matter. We have to take it into consideration during the operation. So if we need a breast lift, we have to replace the old implant with the smaller ones, because we have to remove some skin and some tissue to lift the breast. It's always like this. Technique is this. And to do that, we have to replace the implants with 1 or 2 size smaller ones.
I see. And how many percentage of cases it happens?
Well, in my practice, I see only not more than 2% maybe. But of course, from the patients from the other doctors, I saw this kind of patients. And the thing is, it's fixable. I mean, no problem with that. It can be better, it can look much more good, no problem with this. Just the thing is, the patient will have some additional scars on her breast. That's the only thing.
And sometimes patients want to correct also the nipples. Do you correct the nipples? I mean, to make smaller, for example?
Well, there is a misconception here. Nipple is something, and areola is something. Areola is the brown area around. Yeah. When we make a breast lift surgery, we definitely make it smaller, or breast reduction. Always we do it. But for breast implants, making them smaller doesn't work that much, because if you make them smaller and put the implant, because the implant push under the skin, it gets bigger again. So if it's not so big, of course, there's no need to make them smaller. But for breast reduction, for breast lift surgeries, we make them smaller, and we have got a template which the aesthetic diameter of an areola should be 4.2 centimeters. So this template, we put it and we make it smaller to that dimension.
And does it have some additional complications, or it's okay? I mean, it's not reduction of the nipple. Does it have some complications, or it is?
No, it has no complication. I mean, it doesn't make any complication for sure. Just the biggest thing is it may come back again. It may be in the same size after 6 months or 1 year.
And what is the places you place the implant?
Well, that's a very good question. I have a lot of debate with the patients for years that the patients read Dr. Google and when they Google it, everybody says, okay, implants under the muscle is better, it doesn't say in the future, tell your doctor it should be done like this. It's not true. Normally, the place of implants should be put is under the breast tissue, over the muscle. Okay, under the muscle is something not natural. We are preparing a pocket which should not be there. We use under the muscle implants only for the patients who has almost no breast. And when we put the implant, because it should look natural. And by the way, under the muscle doesn't mean that implant is completely under the muscle. The upper one half of the implant is under the muscle, still the lower one half is under the breast tissue. Because to put the implant there, we have to cut the muscle from one side to another. And when we cut it, it's a small muscle, by the way. Everybody thinks it's a very big one. No, it's a very small one. And it goes up a little bit, and it just only protects the upper part of the implant. But for very small breast patients, what we need is to cover the upper part of the implant to give them a natural look. So we do it only for these patients. But sometimes, as I told you, patients insist a lot that I want to implant under the muscle, I read a lot of things, etc. And I say, okay, we can do it. The risk for under the muscle implant is a couple of years later. If there's a kind of sagging in the breast, which may happen for different reasons, like gaining and losing too much weight, having a pregnancy, and etc., then because the muscle attach the implant to where it is, the breast sags in front of the implant, and it looks like a double shape of breast, which we call waterfall effect. And if it happens, really, it's something that looks very ridiculous. I mean, it's not natural. I explain this to the patients always. So, if a breast implant can be done under the breast tissue, this is the safest way for women to have breast augmentation.
And what is the point of entrance of the implant?
Well, I always put it under the breast tissue, just a small cut under here. Okay, I don't prefer. There are a couple of techniques that can be performed. The first one is it can be done around the areola. But when we do it around the areola, the risk is, first of all, most of the breast implant patients are young ladies, so they will have a future, they will marry, they will have some kids, and they're just gonna want to breastfeed their babies. And when we make it just under the areola, and when we cut through the breast tissue, we may have some damage to the milk in the breastfeeding in the future. It may happen. The second thing is breast tissue itself is accepted as infected tissue. Okay, so there are some bacteria inside. Okay, normally it doesn't give harm to any lady. They don't understand what it is. But when we cut through the breast tissue, there's a risk of micro-infection around the implant, which may result in some capsule formation and etc. So to get rid of all these risks, I put the implant under the breast with 3 or 4 centimeter cut, which heals by itself, and almost 1 year you cannot see even a scar there.
Okay, and what are the recommendations that you give to the patients after the surgery?
Well, after the surgery, the most important thing is they should observe their breasts, because there are some risks that may happen after breast implant surgery, which is capsule formation. And this is something really belonging to the patient's body structure. It's not belonging to us or to the implant itself. If it happens, patients should be aware of this, and they should make some massage on it, and they should keep it soft. If they feel, for example, they should always, maybe a couple of times in a week, they should touch their breast and they should see if they are soft and if they are the same. If they realize that one side is a little bit harder, it's not the same with the other side, then they should begin this massage immediately so they can fix this problem in the early stages. If they cannot do this, if they don't have this awareness, then in the future they may need a second operation to get rid of this capsule formation. This is the biggest risk of the implants, which is nothing, it can be fixed anyway, but patients should be aware of this.
I see. And how long the patient should wear the compressive clothing?
Yeah, we do a special bra. To be honest, it's not so special. I mean, it's the same with the sports bra that ladies use every day. The thing is, it should not have a wire underneath. That's the point. And they should protect the breast itself, and we suggest the patient to use it for 2 months after the operation, day and night, as much as they can. After 2 months, they are free. They can use bra, don't use bra, or use any kind of bra they want.
Does this cause any discomfort, this compressive clothing?
No, it's not a compressive clothing. It's just a bra. I mean, just only for some patients, when we make under the muscle implants, we put an additional stripe here that push the breast implants down. It's a little bit uncomfortable. They have to use it also, but it's like only for 1 month.
I see. And after the breastfeeding, when the patient can consider the surgery?
Yeah, after breastfeeding, they should wait at least for 9 months. Because still for 9 months there's a milk inside the breast, so during the operation if this milk comes out from the nipple, which it may be, it's a risk of infection. So they should wait for 9 months. After 9 months their breast gets to the normal volume again, and then an operation can be performed.
And when they can plan the childbirth after the surgery?
Well, after the operation, after 3 months, they can get pregnant. And when they get pregnant, it takes another 1 year, so it means it's safe after 3 months to have a pregnancy.
And does the patient lose any sensation in the breast?
This is really, really very, very low in percentage, less than 1%. In my life, only 1 patient happened like this. One side, she completely lost her sensation in nipple areola. And sometimes it may happen, but it's something temporary. In a couple of months, it comes back again. Okay, this risk is really very, very low. It's neglectable.
And when you place the implant under the muscle or under the skin, does it change in the sensation, of the breast when you touch it?
You're talking about the feeling when you touch the breast. Yeah, as I told you, if the patient has enough breast tissue in front of the implant, when you touch it, you don't feel the implant, you feel the breast. And if she doesn't have enough breast tissue here, we put it, as I told you, under the muscle, but still, for these patients, the lower half is under the breast tissue. It's a little bit more, you can sense it, you can feel it. But anyway, now the implants that they produce is really very, very similar to the breast tissue itself. So when you touch the implant, you feel that you're touching a breast tissue. There's no need to worry about this too much.
Does it have some lifetime, the implant? Does it need to be replaced in the future?
All the implants produced right now gives a guarantee of 10 years. So this means that after 10 years, the patient should get a check with ultrasound at least, or maybe an MRI scan, which shows that if implant is intact, if there's no problem or not. If there's no problem, they may continue to use it normally. But if there is a kind of risk, any suspicion, they should be replaced.
If the patients have some problem with the breast,
Malignancy? Breast
some
cancer?
some good formation, benign formation.
Benign formation, yeah.
Does it
cysts, we are talking about,
right,
the breast
something like
cysts.
this.
Yeah.
Does it have some contraindication for the surgery?
No, definitely not. Because in either each technique of the breast implant surgery, even under the muscle or in front of the muscle, we are not touching the breast tissue at all. We are always beneath the breast tissue. So breast tissue is in front of the implant, intact. So there is no risk to have an implant surgery for these patients. And by the way, like maybe 60 or 70% of the ladies right now has a very small or a little bit bigger cyst in their breasts.
And it cannot provoke some...
No, definitely not.
I see. And how many surgeries per year of breast augmentation do you perform?
Oh, okay.
Approximately.
Approximately. Let me say you that in a month I do at least 20 or 25, so in a year it's more than 300 or maybe close to 300, in between 300 to 400 breast implants I do per year.
I see. Regarding the rhinoplasty, what kind of technique do you use?
Well, I always do open rhinoplasty. I don't prefer closed rhinoplasty because the difference in between is only a cut here in the columella, which will give a scar which is not going to be visible by anyone. But it's very comfortable for me in the operating room because and I opened the skin from here, I can see all the cartilages and all the bones there, and I can make all the adjustments I want, and I see the result immediately. So the preference of closed or open rhinoplasty is really depending on the patient itself. For years, I prefer open rhinoplasty because it's very comfortable for me and it gives a good result in my hands, so I do it.
How you decide with the patient what should be the shape of the nose? Oh.
Yeah, it's a good question. Sometimes patients come to me with some pictures they want to be, and most of the time I see these pictures. I see these pictures not to make it like this. I see these pictures to understand what's in the mind of the patient, because some unrealistic expectations should be understood before the operation, and we should take the patient in a reasonable ground. It's very important. They should understand what we can do. I know what I can do because I do it for 23 years, and I know what I can do in my hands, and I explain them before the operation what I will do for them and what I can do for them, and if we agree, then we do the operation. So the shape of the nose depends, of course, a couple of factors. The first one is the anatomy of the patient, and the second one is the expectations of the patient, and the third one is my skills. So if we can get an agreement in all of these three options, then we can do the operation.
Do you do a picture or some kind of
well, there are some simulation programs we are talking about. I
Yeah.
think, yes, I take the pictures of the patients and try to make some simulations. Sometimes I make a simulation and patients say, can we do it like this? Can we do it a little bit more? I say no, because this is close to what I can do. Of course, we are not computers. What we do in the operating room is I try to make it as close as I did in the simulation for sure. But the other important point is, it's a very important aspect, by the way, the healing of the patient. Because when we finish the operation, immediately a healing process begins in the body. So what we can change is, as I told you, we can change the bone, we can change the cartilage, but we cannot change the healing under the skin of the nose. This is very important. And so simulation works. Simulation works in two aspects. The first one is we show the patient what we can do for them, and we understand the patient, what does she think or he thinks about the nose in his mind, and then again we will decide together, and then if she agrees what I can do, if I agree what I can do for her or for him, then we do the operation.
And approximately in how many percentage normally you are close to the visualization? How much you're close to the visualization, to the picture that you get on the phone, and after that on the nose?
Well, I tell you what, when we finish the operation, we take the pictures of the patients, and then we show them, and if it's a really good looking and natural result, they forget about this simulation, and neither me myself. But these simulations, we put it in the operating room in a screen, and we check them also, and like 90% we get close to the simulation I did.
And the photos after the surgery, are they similar to what the patient have like after 2-3 months, or it differ?
Well, the photos after the surgery is the result that they will see after 6 to 9 months. Because just after the operation there will be a swelling, there will be some wound healing underneath the skin, and also inside the nose, outside the nose, and then this process is going to end up in between 6 to 9 months. So after 9 months, the patient will see the result that we did in the operating room.
And do you put the tip of the nose upper because it's sagging, or it doesn't sag too much after?
Yeah, what we do is, we put it a little bit higher than it should be. Because we know that in a couple of months it will come down a couple of degrees. So we just take it in advance into consideration, and we do it a little bit more.
When the patient starts to breathe more or less normally after the surgery?
Well, for the first 1 week we put a special silicone splint inside the nose. If they can clean the blood clots and everything around the splint, they can breathe. But sometimes they cannot do it, but no big deal. After 1 week we just remove them, and then they can breathe very easily. And then of course, like outside the nose, inside the nose there will be another swelling period, and it's gonna be subsiding between 4 to 6 months. So in about 6 months, they can breathe 100% with it.
And also the same question, how many rhinoplasty do you do per month and per year?
A lot. I cannot count it. So, like maybe 30 or 40 per month. So it's
Like every
1,000 in almost, yeah, not like every day, yeah, almost every day, sometimes twice, 2 operations per day we do. I do a lot, and it's almost 1,000 per year.
And can you tell, if it's possible, of course, to estimate how much revision do you have?
Well, my revision, yeah, of course. All the plastic surgeons dealing with rhinoplasty knows that the patients may have some revisions. What is important is the revisions are not so big. I mean, so what we do is sometimes, as I told you, there will be a scar formation here and some kind of healing that we cannot intervene anything. It will happen by itself. It may result in it may result in some kind of suppurative deformity. For these patients, we have to open a little bit and remove this scar from here and elevate the tip a little bit more. This is the biggest revision I do, and it's less than maybe 5%.
I see. Okay, thank you very much.
You are very welcome. It was a pleasure for me.
Thank you very much.